Welcome in, everyone. I'm John T. McCall, Senior Pastor of the Bethel Missionary Baptist Church in Pasadena, California. And this is the week leading up to Father's Day. And today we have a panel of medical experts and pastors who are with us today. And we want to look at African-American men health disparities, and particularly on prostate cancer. So thank you for tuning in today. I want to present our panel that's with us today. And we have several other pastors who will be joining us today during this conversation. Tune in, bring your loved one along today as we look at this really critical issue of prostate cancer and health disparities in African-American men. I want to begin today with Dr. Dorff with an introduction, and then moving on to Dr. Ashing and City of Hope employees, James as well, and then our pastors. Dr. Dorff.
Hi, I'm Tanya Dorff. I'm a medical oncologist at City of Hope. I am the section chief for the genitourinary cancer section, and my research and clinical interests, so the patients I treat and the clinical trials that I design and run, are focused on prostate cancer.
Thank you. Dr. Ashton.
Good afternoon. Thank you so much, Pastor McCall. Thank you, Dr. Dorff. I'm Kimlin Ashing. I am a psychologist by training and Associate Cancer Center Director for Community Outreach and Engagement here at City of Hope. So warm, wonderful June gloom greetings from City of Hope. And we are honoring Juneteenth, which is the announcement of the abolition of slavery among Blacks in the U.S., as well as Father's Day. I want to focus on our work that involves community engagement for community well-being and cancer prevention, including prostate cancer. Thank you.
Thank you.
Hi, everyone. I'm James Morrison, project coordinator here at City of Hope, working under Dr. Ashing, focusing on primarily prostate cancer and working with the Eye Care Consortium. Thank you for having me on.
Thank you. Pastor Skinner.
Hi, I'm Tyrone Skinner. I'm senior pastor at the Metropolitan Baptist Church in Pasadena, right up the street from Pastor McCall, who is my great friend, and I'm glad to be here.
Okay. Pastor Simons.
I'm Pastor Sejo Anthony Simon. I pastor the Covenant City Fellowship Church in the city of Santa Ana, California, Orange County. I'm friends with Pastor McCall and Pastor Skinner, my fellow pastors, and it's great to be here and be with all of you.
Well, thank you to all of you today, especially to our City of Hope staff and our pastors and colleagues in the ministry. This topic of cancer, prostate cancer, the C word, frightening when you get the diagnosis of having cancer. Dr. Dorff, can you tell us about the work that you're doing in combating this dreaded disease?
Yeah, and thank you so much for the opportunity. What we know is that African-American men are about twice as likely to be diagnosed with prostate cancer. So they're at greater risk for reasons we don't understand necessarily. And because there have been barriers and disparities in access to healthcare, they're more likely to die from prostate cancer. And that's something that's unacceptable. Research shows us that if African-American men with prostate cancer come in and get the prostate cancer treatments that we have, that they actually do great. They respond very well. The treatments benefit them. But it's a question of being diagnosed. No one wants to be diagnosed with cancer, but if we are able to diagnose early through screening, then the disease can be cured, and then you'd never need to meet me because I tend to meet men with more advanced stage prostate cancer. So for City of Hope, it's really important to help with screening and prevention in addition to treatment. But yeah, my focus is on developing novel treatments because as good as our treatments are, they do still fail for a lot of men, and we are always looking to do better. So one of my tasks is, or interests or goals is to reduce disparities. I've been really honored to partner with great people like Dr. Leanne Burnham, Dr. Rick Kittles in developing some research that's really trying to understand how we can do better, not just for some prostate cancer patients, but for all, making sure that we treat a wide variety of prostate cancer patients.
Okay, thank you. I know our panelists, our pastors have questions, but I want to get through today your presentations first, and then we'll come back and begin our dialogue and asking you some questions. So Dr. Ashing, how about your role with City of Hope?
Yes, thank you, Pastor McCall. So want to, highlight some of the things that Dr. Dorff spoke about in terms of the need to focus and prioritize Black men. 30,000 Black men in the US will hear these words: you have prostate cancer. We know that some of the risk factors which address some of the cultural issues is that we oftentimes don't talk in our community. So if you have a first degree relative who had a prostate cancer diagnosis, as well as maybe even cancers like ovarian and colon cancer, you may be at higher risk and need to speak with your doctors. So many African American men, Black men, are insured. They have coverage, but may not always be getting the best care. And we know that prostate cancer screening guidelines have shifted over the years, in part resulting from the fact that some of these guidelines and recommendations are not always taking our community into account. When we look at Black men, it's almost necessary for us to have this discussion with our families. Has there been a prostate cancer diagnosis in the family? There's no shame, there's no stigma, even though those things exist in the community. We have to be able to combat those and really talk so we know our risk. Talk to our clinicians, our physicians, let them know that we have heard a talk on this webinar saying that I may be a greater risk, and so have that conversation so that you get the referral and prescription for a prostate cancer screening. And then, as Dr. Dorff said, when diagnosed very early, it is highly, highly treatable and even curable with very, very minimal or no side effects. And so catching prostate cancer early does save lives and quality of life for our men.
Thank you. James, can you share your role as well as City of Hope?
Of course. So I am responsible for the day-to-day operations conducted here for the Eye Care Consortium, as well as being the project coordinator here at City of Hope. So what I do is I go out into the community, we find places, churches, and we give educational presentations. A few that I've given, a lot of the men, they needed the information, but at the same time, they pulled back as I was giving them the information. It's a very taboo subject that a lot of men don't like talking about. However, it's information that they need. So in addition to that, I'm also helping Dr. Ashing, and with the help of you gentlemen, making a building and enhancing a survivorship care plan post-treatment, because we all know you can get the treatment, but there's still life after. So that is what I do.
The numbers, 30,000 African-American men will hear this year the words, you have prostate cancer. Dr. Dorff, can you talk about screening and what type of screenings are necessary as it relates to prostate cancer?
Absolutely. So the main way we do screening these days is through a blood test called PSA, which stands for prostate specific antigen. So that's something that used to be done pretty commonly until there was a temporary time period where it was felt that maybe it didn't need to be done for everyone. And unfortunately, some primary care doctors stopped ordering PSA tests because they became a little bit controversial. But these days, it's clear that it does save lives. And people who are at increased risk, someone whose father or brother had prostate cancer, should absolutely be doing screening regardless of whether the rest of the population it's in vogue or not in vogue. But your community is at greater risk, and so that the screening should be made available, should be emphasized, because by doing that blood test, we can find the cancer early enough that we can cure it and cause less harm in the process of curing than if we wait and find out, because it's going to develop one way or the other, right? Whether you look for it or not. So if you find it early, there's just more that can be done, and survivorship, to Mr. Morrison's point, will be better.
Well, pastors, we pastor men. And the research says that 1 in 7 men in their lifetime are likely to develop prostate cancer. Do you guys have any questions for our panelists today?
I do. Number one, I'd like to know, because I've only had one person in our congregation that has been touched by prostate cancer. We constantly talk about it amongst our men because of what I've gone through on the other health spectrum of the health issue. So I would like to know if there any in Orange County, is there anyone that we can reach out to or contact where they can come and do the seminar with our men so that we can get additional information? That's my question.
Yes, and so City of Hope has about 40 community practice sites. We have 2 or 3 in Orange County, including a cancer center in Irvine. So we can certainly partner with City of Hope, including the campuses and the clinics in Orange County. We're also happy to come down and do an educational workshop with your community. We can also consider virtual platform as well. So happy to come and share this information, because I know sometimes that connection is critically important. So actually, you can share this webinar with your congregation, but actually being there can be a more powerful impact for the community to activate them, as Dr. Dorff said and James said, that it's a difficult subject, but it's life-saving. And it's much easier to have a PSA and prevent it and or catch it early, where the treatment is less invasive and you could go on, be cured, and move on with your life, as opposed to having the more complex treatments that's associated with more advanced cancers.
Okay, thank you. Also, I got a follow-up question while I'm on the mic. Now, I've heard the different numbers. I've kind of paid attention to it. So when should we as Black men start to get screened? Which is the question that I'm now kind of confused in. And then how often after the first screening should we have a follow-up?
Well, it's a very good question, and the recommendations change all the time, which is why it's hard to keep track. So for someone who has prostate cancer in the family, they can look at when that person was diagnosed, and you want to start a good 5 years ahead of that. So the general recommendation is around age 50, with screening every 1 to 2 years. But if your father got diagnosed at age 50, then you would want to start at 45.
Got it.
So there is some impact of the family history there. And the frequency of screening also should be adjusted if the first reading is higher than expected and we want to get a sense of rate of change. Then we might want to do one a little bit sooner. If it's super low, maybe we feel more comfortable waiting towards the longer end of that interval.
Thank you.
Pastor Skinner, you had a question.
Yes, thank you, Pastor McCall. First of all, I want to say thank you for the information and taking the time to spread this information with us. I am very familiar with City of Hope. We've had persons to come out to our men and our congregation and share information with us about prostate cancer. I have about 3 questions. The first one is, how reliable is the PSA versus the digital exam? The second question is, what is the correlation between colorectal cancer and prostate cancer? I think I heard earlier that if that had been diagnosed in your family, that you should also very early on have a prostate exam. My third question is, what is the difference between an enlarged prostate and the problems that come along with that, and the actual diagnosis of prostate cancer, and can that lead to prostate cancer?
Yeah, so if it's okay, I'll tackle the first and third, and then maybe Dr. Ashing can address the second one. So I didn't mention the rectal exam as part of screening, but it is a tool that can be useful because neither tool is perfect. So your PSA can be normal and you can have prostate cancer. And one way that your doctor might notice that is if they do the rectal exam and they feel a lump. On the contrast, a rectal exam, it's a finger feeling one part of the prostate. It can't give us so much information. And so the PSA is useful even if the rectal exam is normal. So they're often used in conjunction, and yet they provide independent information. So like I said, if one's normal but the other's abnormal, you might at least be referred to a urologist, have a conversation about, do we need to jump to biopsy? Could we repeat one or both tests? Could we get an MRI, which is a non-invasive study, to gather more information? There are also some additional blood or urine tests that can shed some more light before you go to biopsy. So I'd encourage men to understand that we're not going to push everyone to immediately get that invasive procedure of the biopsy, because I know that's something that it could be unpleasant and not something people want to do. And of course, if it's going to be negative, you don't want to have gone through it. So we do spend a lot of time and energy and research trying to find ways to make our screening tests perform better, because currently they both are imperfect, and yet they are valuable. We do find even in normal PSA range, if there's a change over time, that can be an important signal. And we've caught men with prostate cancer that was curable by an astute doctor noticing that change from 1 to 3, even though they're both normal. That's a big change in a year or two. And if we diagnose it at a curable state, then it's definitely an advantage for that patient. To your point about the enlarged prostate versus prostate cancer, most of the time when men are having urinary symptoms where it's hard to start their urination, or they don't feel like they can get all the urine out, or it's a slow stream, that's most commonly related to benign enlargement. Benign enlargement can also make the PSA higher, which is why we use some caution in interpreting the PSA results. So it's less common for prostate cancer to present with symptoms. By the time it's presenting with symptoms, in fact, it's much less likely to be curable, which is why we rely on the screening tests. So if you're having symptoms, it may not be cancer. You can get help for those. If you're not having symptoms, you still need the screening test because you could still have prostate cancer.
And in terms of your second question regarding colon cancer screening and prostate, evidence is showing within health services and behavioral medicine that looking at whole person screening is important and could be more effective. So a man can be eligible for colon cancer screening, either a FIT or stool-based test or colonoscopy, as well as the PSA for prostate cancer. And also, unfortunately, if he smokes, may be eligible for lung cancer screening. So that whole person care is really important in terms of addressing the needs of that whole person. Importantly, emerging evidence is showing that families that have breast, ovarian, pancreatic, colon cancer also have a greater risk of prostate cancer within those families. So there's this kind of family cluster of cancers. Now, I have actually all of these except lung cancer in my family, which is why it's important for me to do this work. It's very personal. And so I get genetic testing, um, every few years as they have advances in genetic testing, looking at risk factors. Well, one of the challenges with African descended folks is that we're not included and invited into those um, biospecimen studies and genetic genomic studies as often. And so we don't always know these risks. So what shows up from my screens are two or three, um, variant of unknown significance, VUS. So it's suspicious, but it's not evidence enough to say, well, here's the link with these type of cancers. So we need to advocate with the researchers and join with researchers and clinicians to be included in these studies so we could identify some of these risk factors early and take action in terms of earlier screening, as well as other kinds of treatments that may be available to lower the risk. So hopefully that addresses that important piece, Pastor Skinner. So thank you for that.
Okay. I have one more question, if I may. There was an organization years ago, and we used to do it here with our congregation called Real Men Cook Foundation. I
Mhm.
want to know if either one of you were familiar with that, and are there any organizations that offer that type of service? It was an informational service, but they were working on where there would be a local site. There are sometimes men, especially while they will not go into the doctor's office or go to be tested if it's brought to them, there's a great possibility that they will participate. So, is there any type of organization as that can be offered in our communities?
Important question, Pastor Skinner, and Pastor McCall has raised that with me. So currently, we don't have a mobile screening unit. We have one on order, and it will hit the road late fall this year. So that would be available. Um, in conjunction with that, and currently available for our communities, are screenings that can be done or facilitated through your federally qualified health clinics, your community clinics, and your primary care clinicians. So we want to encourage men, give men the tools, the language, the communication strategies to say, hey, I heard a talk, a webinar that our community may be more at risk. And by the way, I think, Uncle Joe had prostate cancer. So I need to know that I need to know my PSA, and you need to provide me with a recommendation, a prescription, an order, so that I can get this life-saving screening. So stay tuned for the mobile unit. There are screenings right now available for our men through Covered California, through our federally qualified health clinics, and your primary care clinician.
Thank you.
Thank you, Dr. Ashing. I want to pause for a moment. We have another one of our panelists who's joined us. Pastor Turner, will you introduce yourself, please?
Hello, I'm William Turner, and thank you for including me in this most worthy meeting. I had prostate cancer, and they removed it with no radiation chemotherapy. And a couple of years ago, I had colon cancer, and it was removed without radiation. So I'm grateful that I have recovered from all of my major problems, but I'm certainly concerned about other men across the country. As I travel from state to state, I'm encouraging them to have colonoscopies, exams, and please take care of themselves. So whatever I can do as a survival to move the program forward, I am certainly willing. Pastor McCall keeps me abreast of the meeting and the progress. So, and thank you, Pastor Skinner, for joining us in this most worthy move. And it is a fight, it is a battle that we are trying to win.
Yes. Thank you, Pastor. And Dr. Dorff, I have a question. My prostate cancer was detected, on the regular physical after my PSA had gone up. Um, can you give us some helpful information or suggestions of how do we get African American men past the scare or this notion of a digital rectal exam, of coming in and at least getting screened?
Yeah, that's a great point. Most of the time, a digital rectal exam will be done when there's an elevated PSA because, as I said earlier, PSA is not perfect. And so a benign enlarged prostate will make more PSA. And before we do something really invasive like a biopsy, we might want to check the rectal exam. But it's possible these days to get diagnosed without a rectal exam if one's PSA is elevated and an MRI can be performed, to better delineate what's happening inside the prostate gland and then go to biopsy. So if the rectal exam is the barrier, please don't let that prevent you from having prostate cancer screening by PSA testing. But generally speaking, the rectal exam is pretty quick and pretty painless. It sounds unpleasant, but I think if you talk to other men who have had rectal exams, they live to tell the tale.
Okay. Dr. Ashing and James, this is the week leading up to Father's Day. Can you give spouses and children or relatives some hints or messages that would be helpful to give to the male figure in their life to go get screened?
Sure. So, according to research, and a lot of men are willing to go to work. Guys will work themselves to death for their families, but they won't get screened. So, I want them to take that mentality. I will do anything for my family, my kids, my community, and really focus it on their own health. We tend to ignore going to the doctor. If you have a simple blood test, you might ignore it for a month or two. That's the type of activity that needs to cease and try to shift our mind to thinking, hey, if something's here, I can catch it early. And therefore, I can not only be the head of the household like most men want to be, but also still be the man they know they are. So that's generally what I would say. Do it for not for just for yourself, but for your families as well. Keep that same mentality.
Okay. Right.
That is so right on, James. Doing it for your family, for yourself, because we can take care of our cars, washing it, polishing it, making sure it looks good on the road. And our bodies really, as pastors, shepherding our community, it's the temple, right? And so taking care of that temple, part of it is screening. And if people don't want to be a burden to the family, it's a much greater burden. Trust me, I have been a caregiver for, cancer patient in the end stage. If we can avoid that and catch that cancer early where it's treatable and curable, we don't have to face that, extensive, prolonged palliative period. And so being healthy for your family, being healthy for yourself. Um, Screening is life-saving. Screening is preventative. And so you can be much more available for your family if you screen early than if you go into, end-stage disease. So,
As pastors on the call today here, um, what information can you give us that will help our congregation as it relates to healthcare disparities and bringing attention and awareness to that in our congregations? Any one of you? Dr. Ashling, Dr. Dorff?
I think my main message is that the disparities that we see in death rates from prostate cancer appear to be largely driven by lack of access. And that's something that we can fix, lack of access to healthcare. So the way that we keep more men alive and more men in your community alive is by doing cancer screening so we can treat and cure cancer versus having it detected in later stages, like Dr. Ashton was talking about. So disparities can be overcome to a large extent if we just get men in the door and have them get their regular health care.
Okay. Dr. Ashling?
yeah, so along those important comments from Dr. Dorff, some of these barriers to healthcare access has to do with the lack of trustworthiness in the healthcare system. We have been violated by the healthcare system. We have been disappointed by the healthcare system. And so it is a response, it's an adaptive response. However, one of the things that we want to do at City of Hope with the community is say, yes, we acknowledge those things. And it's sad, it's deplorable, but the fact is we have to take charge of our health. So if we are in a clinical situation where we're not feeling respected and valued, change that, clinician. If that clinician is not responsive to your questions about, as a Black man, you need to be recommending colon cancer screening, prostate cancer screening, for me. And if you're not, then you're not being a good clinician. You're not being a good doctor. And so finding another clinician and talking to your community. So you have health ministries. These health ministries may be able to help to give voice to the community in order to how to advocate for themselves to get the orders, to get the prescriptions for these life-saving screenings. And so it's important that despite the discrimination and basically racism within the healthcare system, we still need to work within those healthcare system, advocate for our community, empower our community in order to get the best care, because these are life savings. And we know, as pastors, I'm sure you are dealing with families who are struggling with many issues, including cancer, way too early. And if we can screen and prevent those cancer or make those treatments much more, uh, patient friendly, so it's not as invasive, then it's improves the quality of life. It improves the family quality of life. It improves our productivity within our family and within our society. So we need to activate our community. And despite the racism and discrimination, we need to keep moving forward for our people.
Yes.
If I could just add that, at City of Hope, we certainly advocate for our patients. Across the board, there are insurance companies that might deny certain services or certain treatments. And an institution like City of Hope has a little bit more power to force their hand and to say, this is what's right for this patient. So I recognize that sometimes insurance is a barrier. And that's one that we can't overcome just with our good intentions and our education. But, we are really trying to advocate for our patients to get the right care. And again, being at a very academic institution, sometimes we're just better able to get our patients help, get their prescription drugs covered at a cost they can afford, get them the right treatment that we think they need.
Yeah.
Along those lines, Pastor McCall, if you don't mind, I wanted
Yeah.
to add City of Hope work with our community, including Bethel and other advocacy organizations, including American Cancer Society, to pass a law in California, signed January 1, SB 987. It's the Cancer Care Equity Act, and it allows for patients who are covered by Medi-Cal to petition to their insurers to cover their care at comprehensive cancer centers like City of Hope, where
Mm.
they can get state-of-the-art treatment as well as access to precision medicine that will do genomic testing to tailor the treatment to that cancer, as well as clinical studies that may be important for that patient. So SB 987, it's the Cancer Care Equity Act. And we want patients to know about this. If you are on Medi-Cal and you have a cancer diagnosis, petition your insurers. Not all cancers are covered. The law states complex cancer, but that's wide open what complex cancer means. And we know in this case, activation of the community to seek approval from their insurers to come to comprehensive cancer centers like City of Hope and others in Southern California will afford them the best care. So SB 987, the Cancer Care Equity Act.
That's important to know. That's really important. Pastor Skinner, had a question?
Well, first of all, I want to thank Dr. Ashing and Dr. Dorff because you hit on two topics that really a problem in communities of color, if you will, and that is the socioeconomic piece, and also the racism, the systemic racism that has been involved in medicine, and why Black men especially have a fear because of the stigma of medicine in general. But another piece, and I don't want to mix apples with oranges, but another piece is the mental health piece also. There are, in our community, there are people who are suffering from mental health issues, and that prevents them from getting care in general health care in other areas. And I'm wondering if City of Hope, I heard Dr. Dorff talk about the socioeconomic piece, but I'm wondering, is there any type of help to bridge those two pieces, the mental health and the general health piece, especially as it relates to Black men and prostate cancer?
So, Pastor Skinner, I can start. So, at the front end, in terms of screening, yes, I mean, depression and anxiety could be a factor, a personal level factor, an individual level factor that would reduce the motivation or the desire for healthcare seeking. And that's where giving one permission to say, I'm experiencing depression, I'm experiencing anxiety, and these are also very, very treatable. And seeking support within the community, within the family, to get to the right services can provide relief for that person so that they can live life to the fullest. In terms of at City of Hope, and I would imagine other cancer centers as well, we have a very robust supportive care medicine component that has an array of services to deal with whole person care, including spiritual well-being, but also addressing the needs in terms of, the social network, social functioning and isolation. We know, social isolation is a horrid comorbidity that can happen. And if you feel a sense of shame or stigma, I have cancer, I can't talk about it, there are also services and resources available within City of Hope, support groups and networks to address those. In terms of the societal or social determinants of health, we also do an assessment with our patients, and certainly part of the Eye Care Consortium looking at prostate cancer needs of Black men. We're also measuring and addressing the societal determinants of health. So issues of, food insecurity, housing, transportation, and how all of these factors influence access to care, adherence to care, or completing your care and following the doctor's orders. Granted that you trust the doctor is giving you the right, treatments and caring for you as with dignity. Then we have supports and structure to attend to those. It's not perfect, it's in its pilot stages, but we do recognize the importance of true whole person care, and making every effort to attend to those needs so that the person can have those things taken care of so that they can better attend to their cancer, complete their treatments, complete their visits, so that they could be, hopefully cured, and have, the best quality of life possible.
So I think you spoke very well about the importance that City of Hope and other comprehensive cancer centers place on whole person care, and mental health is certainly part of that. And we do really have great resources for our patients that many of them have found really helpful as they're coping with the diagnosis, and how that's going to change their identity or their relationships as they're going through treatment. But to get back to the initial question also about how that impacts people accessing healthcare, it's a huge issue. There is a shortage of mental health care professionals, and there's a huge need. So that's, I think, one area where we'd really be looking to you as pastors to notice when people need help, and maybe together with family, just really encourage people to recognize when they are struggling and what impacts that can have, and try to mobilize community support to get people to look for help so they can be better.
Wow. Thank you all. I want to move this last part of our time together today, if we could, to talk about the Eye Care Consortium, and discuss this phenomenal work that you guys are doing, and then how pastors can become involved to help.
Thank you so much, Pastor McCall. And you are the community co-PI. So this is very much a community partnership to address the unique needs of prostate cancer among Black men. And so this is a consortium with Mayo Clinic and City of Hope and 100 Black men. We have 5 projects associated with the Eye Care Consortium dealing with the continuum of prostate cancer, right? At the point of diagnosis. Another project is dealing with at-home care. My project is looking at survivorship care plan, as James mentioned, and also looking at the societal or social determinants of health related to how that is and survivorship outcomes. And a led by Dr. Solomon in Nigeria, focus on the integration of stress factors, as we were just talking about mental health, and its impact on survivorship and quality of life. So we're covering a broad component of, prostate cancer. In the survivorship care plan component, we know that the Commission on Cancer recommend a survivorship care plan for men so that they could understand the treatments, the side effects, the recommendations for follow-up care, and other kinds of tests that they may need, as well as healthy lifestyle practices. So we're working with the community to hear their voice, so that our survivorship care plan that we are tailoring specific to Black men would be responsive to all of those needs, including addressing co-occurring chronic illnesses, because we know, unfortunately, men may also have diabetes, and other kinds of, chronic illnesses. There may be financial challenges, so there would be components in the survivorship care plan about resources, as Dr. Dorff talked about, in terms of medication coverage. That's an important piece. Oftentimes, prostate cancer survivors are on lifelong, hormonal treatments and all of that. And so coverage for the medication would be important. We are addressing physical functioning, other kinds of social and psychological components. Again, giving, interventions and recommendations around, supportive, family support, social support, spiritual support. So isolation is not something that one has to deal with while they're also coping with prostate cancer. So we're very, very excited to invite other pastors to join in this consortium, to join in this movement. With your blessings, some of this would be featured on a cancer channel that would discuss the eye care consortium, so that we can broadly educate and activate men into screening as well as survivorship care across the country. And actually, eye care has aims for global reach as well, because prostate cancer is a disease that also impacts African ancestry men all over the world. And so we want to reduce the burden for our community here in the US, but also globally as well.
Thank you. Thank you for that. Pastor Turner, I think you want to ask the question, sir.
Yes. Well, first I want to thank City of Hope and Mayo Clinic, who's worldwide recognized and renowned for your services. Because of some technical difficulties, I'm late getting on, but I have a question, and that is, are you available? Have you dealt with that, having portable units to come in certain communities and do testing?
Yeah. So thank you, Pastor Turner, for that. We did mention briefly about it. And so we have a mobile unit in order. So it's not on the road yet. The tires are not on. For late fall, that would be available for mobile screening in the community. And we want to focus on whole person screening, so that in one appointment, they can have their prostate screening, colon, screening, given a stool-based test, get a recommendation for lung screening, unfortunately, if they smoke or have exposure to tobacco. So it will be a whole person screening approach. In the meanwhile, there are readily available cancer screenings within the community. So we encourage men to reach out to their federally qualified health clinics or community clinics to schedule a PSA, as well as other cancer screenings that may be important, and contact your primary care clinician and say, I heard this on a webinar from Bethel Baptist Church, and I need to get your order, your prescription for my prostate, my PSA screening. So activating the community is critically important, and not being so deferent to the doctors, because they're not always mindful of these cancer screenings that are important, so very, very important for us in terms of saving lives.
All right. Thank you.
Pastor Simon or Pastor Skinner, do you have any additional questions that you would like to ask today?
No, this has been very helpful and eye-opening for me, I can say. Thank you for your time, and thank you for the work that you all are doing in those areas. And I'm going to try to connect, or do my best to connect, so that we can get this in Orange County, or connect with the partners in Orange County. Um, One of the things that we're looking to do is be able to promote a prayer breakfast for men, and then the speakers can come, and that'll be a gathering where the men will be there to get the information. And especially, like I said, for me, because it changes so much in our community, um, that we don't know one way or the other. So this is helpful to me.
And I want to also say thank you. First of all, I want to say thank you to Pastor McCall for
Yes.
bringing us together to receive this information today. It has been extremely helpful. I want to thank uh, the doctors at City of Hope and all of the participants from City of Hope. Thank you, James, for sharing with you. James, you may have been out to Metropolitan before. I don't remember or know, but I do know that before the pandemic, we had representation from City of Hope to come out to talk about this very thing. This is vital for our community, for the men of our community. And I want to just say thanks to City of Hope. The access and equity piece is extremely important. I am on the advisory committee for another medical institution here in the city of Pasadena for the Community Advisory Board. And that is one of the main issues that we're dealing with is equity and access.
Mm-hmm.
And while healthcare is trying to be equitable, you can't be equitable without the proper access. That's
Mm.
why that mobile unit is important. That's why the information sharing is important. And again, thank you for being here to share today.
I want to thank all of you and my pastor friends and colleagues today. You know, I'm a prostate cancer survivor, 12 years in now. My father had prostate cancer. I have an older brother who has prostate cancer. And so, given that we know from research that prostate cancer is one of the most common cancers in African American men, but if detected early, it's very treatable and curable. And so I'm excited about all that we've heard, the survivorship plan with iCare, and all of what City of Hope has to offer. And I just believe on this upcoming Father's Day that the best gift to give to an African American man is a medical screening. Whether it's a physical or prostate exam, go get yourself checked out. I think is the message that we want to echo. I want to give today our panelists from City of Hope the last comments to give your final comments today on this webinar.
Dr. Dorff?
Yeah, I would just like to say thank you so much for tackling this important and sensitive issue. I think the more people talk about it and can see that going through the process of cancer screening, and even if it results in a diagnosis, there is that other side. There's that life post-cancer, that cancer doesn't have to end up derailing your life or defining your life. So I think it's beautiful that you're promoting cancer screening and sharing your story. I think that's a very powerful way to help men overcome their hesitations about getting screening.
Thank you.
James?
And I would like to say thank you to the panel for having us on today. And I would like to say, don't isolate yourself. That is the worst thing you can do. Use your connections, stay close to your family, go to church if that's what you do, or if not, join a support group. During those times, that is not the time to be alone. So also thank you guys again for everything.
And it's an honor to be in the presence of the pastors who are leaders in our community and leading voice and activism for health within our community. We want to preserve our health and preserve our legacy within the community. And so want to echo Pastor McCall in terms of the best gift for Father's Day and Juneteenth is the gift of screening. Um, we try to be healthy as possible. So eating more plant-based fruits and vegetables, avoid alcohol, quit smoking if you do, and get screened for a healthier you, a healthier family, a healthier Black community. And so thank you.
Thank you. Thank you to our panelists today. And I want to thank Eric Chambers, our media director behind the scenes, who's orchestrating this today and recording this for all of us. Be available on YouTube and on the Bethel website as well. Thank you to those today for tuning in, and to our panelists today, the medical team from City of Hope, and to our pastors today. I appreciate you. And to the men, happy Father's Day to you, and be blessed.
Happy Father's Day.
Happy Father's Day.